And joining us now to tell us how the Canadian healthcare system compares with other countries in the Organization for Economic Cooperation and Development, here's Peter Jarrett. He's senior economist with the OECD and author of the OECD Economic Survey, Canada 2010. And I'm going to start by saying, welcome home.
Thanks very much.
You are from Toronto. You left here in 1975, and you've been living all over the world since then. So welcome back to your home and native land.
Thank you.
Here are, let's pull a couple of bullet points out of your report and then we'll chat some. Michael, you want to bring this up here? How we rank among OECD countries. In terms of breast cancer, 5-year survival rates, 3rd in the OECD. Cervical cancer, 5-year survival rates, 2nd in the OECD. In-hospital mortality rate from myocardial infarctions, heart attacks, 13th in the OECD. Prevalence of diabetes, 20th in the OECD. Death from treatable conditions, 6th in the OECD. So a mixed bag of things there that we want to get into. Overall, though, how do we compare with other countries in the OECD?
In terms of performance, you've given some hard data. There are softer data, people's satisfaction that we report on as well, which are of more concern, that people are not as satisfied with their health care system, it seems, as some of the other OECD member countries. Canada has quite a different system, and obviously a lot of Canadians are constantly looking over their shoulders at their big brothers down south.
Sure. And one of the quotes I pulled out of this thing was, the Canadian healthcare system is unusually, quote, narrow but deep. What does that mean?
Deep meaning that there's universal coverage. I mean, we don't have the problem that they have in the United States where people don't have health insurance. I mean, everybody is covered for Medicare services. But the Medicare package, the core package that the government is, the provincial governments are required to cover, is narrow. In particular, it doesn't cover drugs, prescription drugs. And that's a big gap, and one that concerns us quite a lot, because this is where the real growth of healthcare spending is taking place, and almost certainly will continue to do so over the coming decades.
Having said that, there are, and we put a couple of them up just a moment ago, there are things about our healthcare system that seem to put us at the top, near the top of the list, in things like treating breast and cervical cancer. What do you think that is?
Well, that's a testimony to the skills of our professionals, and no doubt they're as well trained as any around. No problem with that. We don't, because we're economists, we're interested in the way the system functions and whether it's efficient from a cost point of view, and whether it could be reformed to get more value for money, so to speak.
Okay, well, then on the other hand, we're not doing so well when it comes to deaths from a heart attack in the hospital. What, any thought about why we're doing so poorly there?
I think that you really have to ask health specialists on that. We just want to draw some conclusions so that we know whether or not we're running a Rolls-Royce kind of a system or an old jalopy. And the answer is neither. We're somewhere in the middle, as you say, with a number of things where we do rather well. On heart attacks, we don't do as well. There's a little suggestion in there that it may be due to the fact that we don't use stents as much as other countries, but we're not medics in where I come from.
Okay, gotcha. How about on wait times? The provincial government in particular in the last 4 or 5 years has made lowering wait times for particular procedures a real high priority. How do we compare in that regard to other OECD countries?
In those particular areas that were allocated these extra funds in a federal-provincial agreement back about 5 years ago, we're now doing fine. The question is, are we focused so much on those that we're neglecting other kinds of treatments that may be just as important?
What do you think the answer to that is?
I think it isn't clear. I think some of the procedures that were chosen were good ones because people can't function without good vision, for example. So I think that makes sense. I think personally I'm less convinced about whether hip replacements, whether we should be encouraging that. It's of course tied up a lot with the question of overweight and obesity conditions. And
you're saying
if
that
people,
you're in good shape and your hips are okay.
No. All I'm saying is that there's what we call moral hazard. In other words, if people know that there's no problem at all, you get your hips replaced when you have any problems, then they'll make less of an effort to avoid having the problems in the first place.
I see. Okay. Well, since you are a health economist, let's follow the money, as they used to say in the Watergate days. And if we can, Michael, here's this chart we'd like to bring up here. Total health spending as a share of our economy. And not surprisingly, that bold red line on the top representing the United States, we've all heard this for a long time, they spend a much larger share of their economy on health care. We're much below them, but we appear to be above average as it relates to other OECD countries.
Right.
So, you know, bottom line, are we getting our money's worth?
Mixed answer again there. I think that income or per capita incomes are the key determinant in comparing countries' spending on health care. And Canada is above the line. In other words, for the amount of income that we have, we do spend more than, but not a lot more, but somewhat more. So we probably could get a little bit better value for money if we were doing things on average. But I think that we can aim a little higher than that, and I can say that we think that there are ways that we could get even better value for money if we were so inclined.
For example?
Well, the way we pay our doctors, it's still largely, I mean our general practitioners, it's still largely the old-fashioned what's called fee-for-service. And when you pay doctors fee-for-service, they're going to try and render as many services as they can to occupy themselves fully during the day, maybe not to work weekends and things like that. But the incentives aren't really to save money for the health insurance system, the public health insurance system at all. So we recommend introducing a greater proportion of GP pay based on what's called capitation, which is like a fixed payment for each person that they're responsible for, whether or not the person's in need of any treatment or at any particular time. That way they would have a lot greater incentive to deal preventively with a lot of the problems.
Are we pursuing that quickly enough?
Well, quickly enough. It's moving in the right direction. It could move faster.
Okay. One of the things that other countries have done that you recommend we do as well is introduce more co-payments into our system.
Right.
First of all, just tell everybody what that means exactly and how you think that would, or maybe share the experience of other countries that have seen costs reduced to the taxpayer as a result of that.
Well, obviously, if you want to go to see your GP and it's free, you will be less dissuaded from doing so with a little sniffle if all you're doing is having to get to the GP's office and maybe sit around in the waiting room for a little bit of time till he can see you. We don't advocate charging the full cost, which might be something like $50 or something to have an appointment, but a small charge of maybe $10 or something like that would cause people to think twice. On the other hand, we wouldn't want people with chronic conditions to have to pay thousands of dollars for visiting GPs, for example. So there should be a cap on this. But almost every other country in the OECD, certainly those that are in the major 7 that we usually compare ourselves with, they don't have this ban on co-payments.
And how have they avoided having poor people, disproportionately affected by this kind of thing?
Well, as I said, the key thing is that people with chronic conditions you would give a pass to or whatever, and everybody you would set a limit on, so that if somebody had a bad year where they had a lot of health problems, they would still have a limit of maybe $100 or $200. But you'd get a lot of money into the system, and you would restrain demand, because people would, no doubt, as I said, think a little bit about if they have relatively trivial things that they think that would go away on their own, then they would perhaps not pay that extra visit to the doctor.
Let me ask you, you raised the issue of drugs earlier and the fact that we do not have a national pharmacare program, if you like, here. We do have, I think, a pretty good, most people seem to think, a pretty good program in Ontario where if you got a job, you know, chances are you're covered. If you're on welfare, you're covered. If you're a senior, you're covered. Not everybody's covered, but I think we've got 90% or 85% covered here.
It's probably like about 80, 85%, but a lot of people aren't covered all that well either. They're not very extensively.
So would you recommend, I think, on the one hand, we got to contain costs. On the other hand, you've identified something that says,
holes.
Yeah, some holes. So how do you expand the coverage of drugs and yet keep the costs under control? Because it's, you know, logic will tell you that's impossible to do.
Oh yes, of course. We wouldn't. We do recommend an expansion of the Medicare system to cover drugs. Why do we do that? We say, right now, if a doctor knows that somebody doesn't have drug coverage, and he's got him in hospital, and for whatever problem, whatever condition that person has, there'll be distortions. He'll say, okay, this guy doesn't have coverage outside. If I keep him inside in the hospital, Medicare covers it. So I keep him in the hospital longer just because I know he can't afford the drugs as soon as I release him. So there's a tremendous waste of resources to keep people in hospitals.
To the system.
Because of the way the system's designed. Similarly, he might say, oh, I could treat this problem if I operate by surgery, because again, that's covered, but it might be medically just as good and perhaps cheaper to society if I send him home and put him on drugs. But again, if he doesn't have the coverage, he might encourage me to encourage the doctor to treat with surgery. So there are these distortions around. Now, the cost, obviously, drugs are something like 2% of GDP. They're something like a fifth of all healthcare spending. And if you're going to bring that in, then of course you're going to raise that component of healthcare spending. But on the other hand, as you said, most people have some kind of drug coverage already, and so it would be a shifting. But as I said, by putting it into the package, you get it treated on an equal basis, and then the doctor wouldn't worry about, does he have coverage, doesn't he have coverage, do I treat with drugs or do I treat with surgery and things like that.
So you'd have medical decisions made for medical reasons as opposed to other
economic
reasons.
Economic
reasons. You know, politicians have told us for a long time that they are really trying hard to bend the healthcare cost curve here. And I know that the McGuinty government right now has said if we don't get a handle on this thing, health spending is going to be 70% of our budget, you know, whatever it is, 25 years from now.
It's up from 50 now. Yeah.
Almost 50 now, yes. Should we take them at their word when they say they really are trying hard to keep the costs under control? Because the suggestion, I guess, one takes from your report is they're not trying hard enough.
Well, one of the problems, I think, is that there isn't enough good, hard information in the system, I think. Canada does relatively well in terms of data that are available. A lot of countries are really at wit's end when it comes to that, and they have to rely on either priors or other countries' experiences. Canada does have a little bit more to go on, but it still could be a lot better, and we need to assess what information we have, and we need to try and get more of it systematized and use more technology. For example, electronic medical records are something that would be very useful to get introduced systematically across the country in a standardized way. Then it would be a lot easier to make cross-province comparisons, because that's one of the advantages that Canada has. We have 10 or 13, if you include the territories, different experiments going all the time, and implicitly these are good laboratory type conditions to test different ways of going about doing things.
Okay. Peter, thanks for giving us the view from the OECD on how we're doing in terms of healthcare compared to other countries. Thanks so much.